and a very warm welcome to Spinal Cord Injury Management. We've got the privilege of Shiva Jamwal with us today, Head of Therapy Services, Consultant Occupational Therapist at the Royal Buckinghamshire Hospital. So we're looking at spinal cord injury management from a therapy perspective. Just a little bit about ourselves, for those of you that don't know us, my name's George. I'm the Business Development Director here at Yorkshire Care Equipment. Our mission is to enhance quality of life, which I guess really sit with exactly what you guys do in terms of supporting clients and patients. We've been working now for 50 years, celebrating our 50th birthday this year, which is exciting, and been working with many thousands of UK healthcare professionals now for many years. We supply equipment over a broad range of facilities such as hospitals, care homes, and to private individuals. So just before I hand over to Shiva, I'm just going to run through a few of our products, particularly the up-to-date products, which will give you just a bit of an idea maybe of what's available. So first of all, this is an event we recently participated in, so the Sportability event, which we did at Leeds Urban Bike Park along with Experienced Community. So this is a group of individuals who've come together and really exploring the great outdoors using some amazing powered and manual wheelchairs amongst others. So I thought I'd just share that. It's a recent event we participated in. So you'll see here just a small range of some of the wheelchairs which many of you will be familiar with, starting with the multi-sport sports wheelchair, which is quite a low price sports wheelchair, which introduces which really is a good introduction for first-time spinal users. And then there's the tilting space wheelchairs, the rears alien and ibis, and then lastly on the slide there, the permobile, so the vertical standing wheelchair. You'll see here a Tenero electric profiling bed, which is a very nice looking profiling bed, which is available with cot sides and grab handles. And then right hand side, our most recent product is what they call a stair trainer, which is going down really well, particularly in hospitals, for physiotherapy and rehabilitation. And then lastly, our Lento range of chairs, which many of you will be familiar with, working from bariatric right the way down to little Lento for smaller adults or pediatrics. These are modular, very easily adjustable, and to suit a wide variety of conditions. So with that, hand over to Shiva. Very warm welcome. We'll look forward to hearing from you, Shiva. I'll stop sharing now.
Thank you, George. And I take over from here. Okay. Can you all see my screen? Okay, I hope you can see my screen and in a slideshow format, because it appears slightly different to me. Okay, I take one nod as a yes, so and I can proceed. So hi, good afternoon, everyone. My name is Shiva. I'm an occupational therapist, and I have been working in spinal cord injuries for over 19 years. That goes to show my age. I've been in the field. I've worked in the private sector, where I am currently in the NHS, worked in the UK and abroad in charitable organizations. So I'm privileged to have different aspects of spinal cord injury and the intervention in different fields I have been working on. And today I'm here to talk about the spinal cord injury, which I'm very, very passionate about, as you would just feel from my tone. This is where I've spent majority of my professional time. So in today's webinar, it's a synopsis of It's a synopsis of spinal cord injury and what is it, principles of rehabilitation. And I'm sorry, I'm just going to change the setting because I can't see the screen. Sorry about that. Okay. Oh, yeah. Okay. And yes, so we will talk about principles of spinal cord injury management from a therapy point of view, and what's the course of rehabilitation, goal setting, tools and technologies, and lifelong care and support, which is absolutely paramount for spinal cord injury. So I assume most of you are from allied health professions, and so I would just take that. And if there is anything, there are any questions, we'll take that at the end of the presentation. You all are aware that spinal cord injury is a catastrophic, life-changing event that results in severe sensory and motor loss, along with other neurological impairments, all of which influence an individual's ability to lead a healthy and fulfilling life. There are 50,000 people in the UK with spinal cord injuries. 2,500 are paralyzed every year. These are the stats from SIA and NSIC database.
Sorry to interrupt, Shiva. The slides are just not moving on. I think I was still on the first slide, I think.
Okay, there's something was happening. So I'm going to stop sharing. Sorry, technology is great when it works. And I'll reshare. Just a second. Stop share. Okay. It worked perfectly, I promise, before we started. Okay, share. Okay. Can we see the slides moving? Good. Okay. Right. So that's where we were. So the causes of spinal cord injuries are broadly classified into two: traumatic causes and non-traumatic. So traumatic result from accidents, falls, sports injuries, injuries resulting from violence. Non-traumatic result from degenerative diseases, infections, tumor. And our average age of individuals acquiring spinal cord injuries changed over the years. Earlier, it was 28 to 40 years. Now there's been a shift to later years, 50 to 59 years of age. 67% of the SCI are incomplete and 33% of the SCI injuries are complete. So there's been a shift of paradigm in the last few decades, where we're seeing more incomplete injuries. We're seeing injuries in the population above 50 years of age, which goes to say that our rehab approach, our approach in the management of spinal cord injury is evolving as well. So what is spinal cord? Spinal cord, you all are aware, so I'm going to whisk past these slides, but it is a bundle of millions of fibers that transmit electric stimulation from brain to the rest of the body. The spinal cord runs through the vertebral canal, which is in the spine, and extends from foramen magnum to second lumbar vertebra, L2, beyond which it just expands like a horse's tail, and that's what it's called, quad equina.
Sorry, Shiva, just one slide. It's not showing, well, it's showing currently on presenter view, so we can just see like a small amount of the screen.
Okay. Okay, host only, all advanced. It's say who can share? All participants.
If you click on the display settings up at the top there.
Display settings. How is that?
Yep, that's great. Thanks. Yeah. Sorry to interrupt again. Thanks.
Yeah, thank you. So there we are. So at each vertebral level, spinal nerves exit and enter to communicate with the specific areas of the body. There are 31 pair of spinal nerves. And where the injury occurs, it all depends on which segment the injury has taken place, and the functional implication depends on, again, where the injury took place. So moving on to the next, where I would explain. Sorry. So the effect of spinal cord injury depends on location of the injury, where it is, on cervical vertebra, thoracic, or lumbar, or sacral. It depends on the severity of the injury, whether it's a complete injury or it's an incomplete. Incomplete means there are certain, at the level of injury, certain fibers are spared and there is some messages can be conveyed to and fro from the brain. And higher the level of injury, that means higher will be the level of paralysis. And a complete injury means that there is no motor, no sensory function below the level of injury. So all these factors will have an impact on what our rehab approach is going to be. How do we, We use ASIA, which is an American Spinal Cord Injury Association classification of spinal cord injury, and which is a universal standardized scale that describes a person's impairment as a result of SCI. So from wherever in the world a patient presents to us, he will present what level the injury is and what is the ASIA level. So with the ASIA level, any professional in the spinal cord injury would know that what to expect. So ASIA A means total loss of power and sensation below the level of injury. ASIA B means it's an incomplete injury. There's a loss of power, but there is some sensory, there is some sensation intact below the level of injury. In ASIA C means there is some power in the limbs, and ASIA D are normally walkers. They have good power in their lower limbs. Spinal cord injury can be central cord. That means the center part of the cord is damaged, which means that they would present with weakness in hands and arms, but would be able to walk. Brown-Sequard is another presentation of spinal injuries where half side of the spine is damaged. So the person would present as a hemi below the level of injury. So it's very important for us to first identify where the injury happened. ASIA is a very complex assessment tool. So it's carried out by doctors, nurses, and therapists. And what it involves is assessment of motor and sensory function at each myotome and each dermatome. So it's a complex one, but it's very, very essential before we set up the process of rehab, goal setting, to know where to start from. And then based on what the level of injury is, there are aspired potential functional outcomes. Now, this chart is one of the many. There are quite a few charts, and I picked this up from Paralyzed Veteran of America. Spinal centers have their own as well. It just reflects at this segment, this is the functional outcome a patient can acquire. So which is very important for the team, because if we take, for example, T1 to T9, we would expect this patient to be breathing independently. This patient would be able to manage their bowel and bladder program independently, might even be living independently, will have a manual wheelchair that they can push, they would be driving. So this is what we are aspiring for in our rehab process. This is what functional level this person can achieve. So it's very important. And the charts really, it can be as detailed as one likes. We've just picked up a few examples just to give you an idea. But of course, rehab doesn't just depend on just the level of injuries. There are so many variables. What is the completeness of the injury? What other complications are associated, secondary complications the patients have at the same time? what have been the associated injuries, if it was traumatic, did they have other polytrauma, did they have brain injury? All these factors will affect their outcomes. What is their pain level? How are they coping? What is the motivation? How is the family support? Pre-morbid, how were they before the injury? How active they were? What is their age, gender, and importantly, what is their relationship with the rehab team? All these factors will determine their potential functional outcome at the end. And spinal cord injury is multifaceted. It impacts and affects an individual physiologically, in social aspects, emotionally. So therefore, the approach has to be multifaceted as well. So therefore, disciplines and specialties come together, and lots of them. This is not a comprehensive list, but just a few. All will have to come together and work in an integrated way, in an interdisciplinary rehab course that is offered in the spinal centers. Just to name a few, a patient needs to have family and patient support, education, bladder and bowel management, upper extremity functional restoration, orthotics, aquatic therapy, locomotor training, spasticity management, pain management, respiratory management, assistive technology, wheelchair and seating, sexuality and fertility, community reintegration, recreation, wound clinic, vocational, pain management, just to name a few. So lots of specialisms come together and work in a holistic way in spinal centers. That's why they're specialist centers, because all these disciplines need to be available there, and work towards maximizing an individual's potential, maximizing their function, avoiding complication, managing complications, and maintaining the physical, emotional well-being. So the principles of rehab that we follow, and they're not set in stones, but this is just a synopsis again, is preservation. Preservation is preserving what they have, the innervated muscles, the function that they have, which is not being impacted by the injury, to maximizing that, preventing secondary complications, preventing complications that might just arise as a result. For example, I will take each of these in details in subsequent slides. Enhancing their participation. It's so important that they are engaged right from the beginning in their management. We teach them self-management, we teach them self-advocacy, which again I'll take in later slides, and preparation. So rehab is giving tools and skills, preparing them to go back to their community, to their own environment, and lead them a meaningful social and economical role. So working on, when they are with us, preventing secondary complications, preventing soft tissue tightness because they are in the hospital and prolonged bed rest, so considerably reduced mobility. So our aim is, as a team altogether, physios, OTs, nurses, to maintain the soft tissue length, prevent contractures, prevent secondary infections, maintain skin integrity, maintain respiratory health if they're, again, because of immobility, and if they are high-level injured, then they might be on ventilator. So that is a huge area physio nurses and the OTs will be tackling together along with the medical input. Management of edema in the limbs, management of pain, management of spasm and spasticity. So if not managed, they're going to lead to secondary complications. So that's why it's so important to look at prevention. One of the ways of prevention, and we all would agree, is positioning, posture management, which is a 24-hour process. And you will see the slide time and again, because I want to just to emphasize how important it is right from the early stage to back when they're in the community. As their changes, their demands, their bodily changes happen, these management program also change and evolve with it. Preservation, how how to maintain their range, how to maintain joint integrity through passive and active mobilization, maintaining the length of the muscles, through positioning, again, posture management, in bed, in chair, wherever they are, splinting, orthosis, stretches, strengthening of muscles above the level of injury, and also because they might be having some recovery, so tapping into that early on. Early mobilization is very, very important in all injuries, and not just spinal injuries, but picking on, because we're talking about spinal injuries, early mobilization, just to prevent issues like contractures and pressure sores, and engage them in rehab as early as possible. There's a lot of thought process that goes behind if they've had a surgical fixation or they've had non-surgical intervention to stabilize the spine. Once the MDT is happy that the spine is now stable, they are ready to be mobilized. Mobilization happens gradually, first in the hospital bed, and then slowly they move on to the wheelchair. I've just put tilt in space wheelchair, but it depends on the clinical needs of the person, whether they would need a specialist wheelchair or they would need a specialist cushion, specialist backrest. Again, it's a very, very individual, but it's an MDT approach in identifying what their clinical needs would be before they sit out in a chair. And when they do, they start building the tolerance gradually and building it up to tolerate sitting in a chair for 6 to 7 hours. Again, seating and mobility, as I said, that this keeps changing. The slide keeps coming back, posture management and seating, because at every stage, the needs would change, and so would the seating requirements. Participation rehab is a partnership. It's a partnership between the patient and his rehab team. So the more each side puts in, the better results we get. So a huge emphasis is on educating patients, and not just the patients, the family members. And the best way is to give them skills, give them knowledge, give them tools in self-management, because spinal injury is so specialist. When they go in the community, they have to be their self-advocate. In the GPs, in the general hospitals, everyone would not know how to manage the condition, so they need to be their self-advocate. Hence, so much emphasis is made on education, and then to take control of where they are, take charge of their rehab program, which is goal-oriented and very and patient-centered. And then we're preparing them. All this converges to preparing them for their functional independence, not only in the center, but back in the community. So this slide is a little bit of a complex slide, because there's so many functions we're trying to achieve. Again, just a few of everything. And physios, OTs, nurse, it's not restricted to that. Speech and language therapists where appropriate, dietitian, nutritionist, all of them work together to give the functional ability, to increase their functional ability. So just to name a few here. And early engagement, as I mentioned earlier, is so important that they start taking control of their lives, because that is one of the things in this injury is they feel they've lost control. So early engagement in function, right from when they've started to sit up, we teach them to be verbally independent even when they can't do things for themselves. So that is a part of their independent program as well, to verbally tell people what they want and how they want things done to them. Participation in small tasks like feeding, grooming, dressing, engaging in meaningful tasks, using a cell phone, using tablets. So as a team, we would look into assistive devices, sometimes we make our own devices, adaptations. There are charities that help. Charities like Aspire, they will help with assistive technologies right from the beginning and work with the team. And then we give building blocks to function, which is like bed mobility, transfer skills, manual handling skills. So we break these into small components, like turning to sides, using bed rails, sitting up. These components are then practiced in the gym when they come to the rehab in the gym. We practice that. We would then practice these skills in their own environment up in the ward. So bed mobility skills like sitting up in the bed, sitting at the edge of the bed, propping on arms with the aids in the beginning, and then slowly we wean off the aids and teach them compensatory techniques, which I'm not going into details because that's not the purpose. Transfers and manual handling, building on to the other two slides, we would identify the best way of manual handling and transfers for them, and which will change in their course of rehab, from when they came in, the middle of rehab, and later when they leave and when they're back in their own community. Identifying the level of assistance required at each stage and handing it over to the family members when the time comes, but in the ward. So there is a consistency of what they're doing in the therapy gym, in the ward and in the ward. Use of specialist techniques and aids, whether they're being hoisted, which type of hoist they're going to be using, what type of manual handling aids they would be using. That would be a collective approach by the therapy team and the nurses. Therapeutic stand and functional stand. Now, this is so important for people with spinal cord injuries to maintain their joint range, to reduce spasms, improve their respiratory health, digestive and cardiovascular system, and it also contributes in reducing the osteoporosis. And so there are various standing aids available. I've just shown few because in the early stage, it could be a tilt table and they're building up to tolerate up to 70, 80 degrees of upright. And it's not just the tilt table, there's again hold MDT, thinking and process that goes behind. Would they need medication because of partial hypertension? Would they need a binder? Would they need an orthosis because maybe the ankle has lost range? Would they need special shoes? So all that work, all that teamwork goes together before they identify, actually, this is now right time to stand them as early as possible, but all this has to be in place first. Standing aids are again, there's a huge variety, whether it's a static standing aid or it's a dynamic standing aid. So to name a few, there are some that we use quite frequently. Thera Trainer, which is again a dynamic standing aid, Struzo, Easy Glide, wheelchairs, because a lot, when patients are going to their community, they might not have two carers to help them, or sometimes even three required to help them on a very specialist devices like grandstand. So there, a power wheelchair that has a stand-up function can be a substitute. It doesn't substitute the standing frame completely, but it's more practical. So it's again a joint clinical decision, considering what is the lifestyle of the patient, what will be the patient, what will be the support in the community. Upper limb rehabilitation, again, retraining, we use manual therapy, we would use electric stimulations, we would use virtual reality, robotics. It is all to engage patients in an intensive rehab, repetitive task right from the beginning. So virtual reality and robotics are quite amazing because you can enhance even the small movement they have to meaningful tasks on the screen, which from my experience has been absolutely fantastic. And then hand function retraining. If they're high level injuries, they will not have, or might, depending on again the completeness of the injury, we would need to teach them remedial or compensatory approach to have hand function. So one of the things that we teach for high level injuries, C5, C6 and above, is tenodiscus grasp. And you may know this trick that we teach, where it's a biomechanical grasp basically with the extension of the wrist, the fingers curl, and we teach that so that in the absence of finger muscles, they're able to grasp and release an object. So we would use strapping, we would use taping, splinting, FES to get that grasp. So these are different approaches we would use. Now, if there is a higher level injury, there would be a lot of emphasis on respiratory health. If they're on ventilator, weaning them off the ventilator, because that and how would this be managed in the community and with the community team, which is a huge job. Psychological support goes throughout, and I cannot emphasize enough on how essential this support is in giving them coping strategies, not only the patients but their family members, because patients will go back in the community and they would have the support, the family needs support as well on how to cope with changed circumstances. Communication aids, and this is again higher level injuries. They would need specialist devices to operate laptops, tablets. There's television, and there are loads of devices available, environment control systems available, that we as a team have to work what will be best for the patient's condition, for the patient's lifestyle. Along with all this, strength and endurance training carries on land, in hydrotherapy, using various modalities, whether it's just simple dumbbells, or it's gym, or it is FES. So just to give an idea, here I've got different slides to say, well, it just is not one or the other way. It's a combination of all these approaches. And introduction of sports. It's amazing thing that, and there's a lot of evidence to say that those who have been introduced or reintroduced to sport early on have better emotional and physical well-being. Charities like Backup and Wheelpower, they facilitate wheelchair sports and are active in these rehab centers. So patients have the opportunity to try sports they might not have tried before, and sports is not just being able to play in a wheelchair. It's a specialist wheelchair as well, and getting used to that wheelchair too is a task. So they need to be introduced to sports they enjoy or will enjoy early on. And all this converges to application in their function in activities of daily living, using the adaptive aids, having the right environment, adapted environment. We teach them how to engage in not only self-care tasks, but home management tasks, leisure activities, social participation, things like how would they load or unload a dishwasher? How would they put washing for drying? How would they cook? How would they actually interact with the people? How would they go out shopping? Because everything has changed. They're in a wheelchair or maybe on any other walking aid. How would they cross roads? How would they go to a bank? So all that training, the social aspect, is our job. So there's so much to pack in that rehab. It is an intensive rehab because it's just not it's not therapy. It's like it is all disciplines working together at the same time. So for a patient as well, it's so overwhelming, and it's so much to take. That's why psychology supports them throughout their journey. Okay, there we are. And as I said, you will see the slide time and again because posture and seating needs to keep changing. So in the beginning, when patients are just sitting in the chair needs to be more supportive. It needs to be more stable. But as they move on to their journey of rehab, they're getting stronger. They're getting confident in chairs. So the chair has to change. The chair becomes more active, less stable, and we just start taking off the support, so like high backrest or higher armrest. So we start weaning them off. The chair's setup would change, so it'll be the wheels will be further forward, so it's smaller base of support. It's more active. It's more thickly. The patient would need that. Again, it is on their level of injury, on individual patients, but as a therapist, we guide them, we facilitate, and we give them enough information to make their own decisions. And it's not only just chairs, it is, and when they're home, would they have different surfaces to sit on? If they're going to be on a sofa, what support they would need on a sofa? So these kind of things, the thinking starts happening while they are with us.
Sorry, Shiva, it's just breaking up a little bit. Might be worth just pausing and it might catch up with itself. It's probably the internet.
Okay. Probably. Is it okay?
Yep, I think that's better. Great, thanks.
Okay. So I'll continue. Can you see my slide with the wheelchair? And it says preparing for the community. Great. So all this while as you've seen, we've given them education, training, skills, strategies. They need to be put into now using the community. So we would give them wheelchair training, which happens from the beginning, but wheelchair training in the community. How would they manage curbs in the community? How would they get on a public transport? How would they go on a grassy land? And there are equipments and aids at each level. So our job as clinicians in the unit is to give them the options that are available, educate them on each option so they can make their own decision. And then discharge planning. Discharge planning I've put down here, but it starts from the day they are in the center. So all the things that I've spoken about, education, family support, all that is going on, but environment and modifications, the therapist would have identified early on if the environment is going to be suitable or not suitable, and start the referral process, start working with the community teams very, very early on, because it's a long process. And this is one of the things that holds back the rehab. Equipment, so identifying the equipment that would be needed to maximize their function, that is identified by the rehab team. If they need care, then working with the social worker on what the care package would look like. Training the carers is absolutely essential, because we are handing over the complexity of management to the carer. So they need to come in and spend some time with the rehab team and get a proper handover, a care plan. As advice on assistive technologies and community support. And in assistive technologies is what sort of if they're going to be driving, what sort of a vehicle they would need. Would they be driving, or would they be driven? Would they be driving using hand controls? Would they be driving seated in the wheelchair? Would they be transferring onto a driver's seat? All these questions are addressed while they are with us. Our job is to educate them on the adaptations available. There are driving centers and mobility centers that would do the adaptations, but we educate them well and what's best clinically suited for them. And then fitness and well-being.
Sorry, I think it's
stopped again.
Crackling. And are you plugged into the Wi-Fi? Have you got a hardwire connection?
Okay. Can you hear me?
It's a little bit better. It's just like a crackling noise in the background.
Performance. I don't know whether it's probably it's the internet. Okay. So and independent living. So they need to practice. If they're going to be going home, it's a drastic change from the hospital environment to going home, and it's absolutely new. So spinal centers or rehab centers have an independent living unit where patients have an opportunity to spend a day with the adapted environment, with a carer if they need, or family members. And once they're happy, staff are happy, they go for weekend leaves to practice the skills they have learned at the spinal centers. Can you hear me? My picture is gone, but I'm not sure if you can hear me.
Yeah, we can. Sorry, Shiva. It was just to help the audio.
Okay, right. Okay, we're nearly at the end of the presentation, and the whole crux of rehab, as I mentioned earlier, is for our patients to return to their roles in the community, return to their life, maybe in a different way, maybe with the adapted environment, adapted equipment, in a different manner. But that's what we are aiming for when they come to us in the rehab unit. So their roles in the family, their roles in the community, in society, being a mom, being a partner, being an employee. That is the success of a rehab when we get them to do these things. Again, we at each stage, for example, if we've had this many times where a parent wants to drop a child to the school, so that would be a slightly different mobility solution, because they have to carry a little toddler and they have to take them to the school. So these are we are always guiding and advising them. Sometimes it might not be most relevant to them at that point of their rehab, or we give them education and tools to put in their bag. And when they are in the community, since we have given that education, they might just think, oh, I know about this. I think I will look up in this kind of a wheelchair because they showed me. So it's always, our aim is to give them the options. They might not take that at this time, but they might find it useful later. So, and it doesn't finish there. Spinal patients need lifelong support. As Sir Ludwig Guttman, who was the founder of the National Spinal Injury Unit, the first one in the world, said that spinal injury patients need support from injury to grave. So ongoing support in the community is absolutely paramount. And this is offered by the statutory services, charities, volunteers, and the spinal centers, who are obliged to provide lifelong follow-ups to the patients. There are many charities like SIA, which provides peer support, advocacy, mentorship, and there are charities like Aspire, Backup, and Willpower that I mentioned in my earlier slides. So over the years, with our better understanding of the condition and its management and complications, we have been able to achieve the higher life expectancy. Now, our complete tetraplegia, we can expect a 70% of the life expectancy of a general population. And for a complete paraplegia, we can expect 86% of the life expectancy of a general population, which is a huge, huge change to how we started in 1944. When our first center was set up at Stoke Mandeville. The average lifespan of a spinal cord injury patient was 1 year. So we've come a long way from them. And that's thanks to Sir Ludwig Guttman, who was the founder of NSIC, which continues to be the beacon in spinal cord injury world throughout the world. And that is the end of the presentation. And sorry about the technical glitches, but I hope being able to give a good idea and overview of management of spinal cord injuries.
That's fantastic, Shiva. Thank you very much. And there's a few questions that are coming. It really, I mean, an impression I've got going through it, the holistic approach that's needed to be taken with spinal injury sufferers. There's so many different areas and facets, isn't there?
Absolutely.
So somebody's asked, what is a binder? I think you referred to that earlier on in the presentation.
Yes, so binder is a strap that goes around just below the abdomen. So we would use that, we call it a binder, but in an orthopedic center, it might be called something else, but it goes just below the abdomen. And the idea of using a binder is to increase the blood flow upwards. And it's a strap, it's an elastic strap, basically, with Velcros.
That's great. And then a question here from Ruth. If you have service users from areas that are not local to you, what and when do you contact the local service providers, and what time frames are you working to?
So service providers, in the sense, are you talking about spinal rehab service providers?
Yes.
So there are 12 spinal centers throughout UK, and each spinal center is linked to a major trauma center. So what happens in terms of referrals is when there is a spinal cord injury patient, they are referred to the spinal centers attached to that trauma center. So depends on postcode where you are and your GP, there will be a spinal center attached to it. So you will have to look at which spinal center is attached to the area. So for example, in London, there is London National Orthopaedic Hospital, RNOH, which is the London Spinal Injury Center. Stoke Mandeville covers a huge area, so I'm not going into the details, but that's what it is. So it's linked to the postcode and the trauma center.
Yeah, sorry, Ruth just added, not what I meant, more about provision of equipment and time frames for major adaptations.
The time for major adaptations vary, but we all know that we're talking about weeks and months. And it, again, is a postcode lottery. Some areas are better than the other, but major adaptations can easily take 3 to 4 months, no less than that.
Great. And then one in relation to life expectancies. What is the main cause for the reduction compared to general population? Is it, for example, due to cardiovascular issues from reduced mobility and respiratory complications?
Yes, one of them, but major cause is renal failure, UTIs, and pressure sores. These are the major complications. A major source of reduced life expectancy is renal complications.
Thank you, Shiva. And are there any stats for the incidence of AD for spinal patients, as this can limit the intervention and rehabilitation?
So I'm not sure if there are stats because I'm not sure what the question is, but the autonomic dysreflexia takes place in injuries above T6. And I don't know what the question is aiming at, whether how many people get AD or what is the frequency of AD. So I'm not sure what the question is, but it occurs in individuals who have injury above T6 level. And AD, it's a reaction, body's reaction, because autonomic function is impaired. It's a reaction to any discomfort, anything that's going on in the body. If there is a catheter block, if they have ingrowing toenails, if there is a discomfort going on anywhere, skin issues, patients at this level, above the T6 level, they would experience hot flushes, they would experience sweating, headaches, which is the body's way of saying that there is an issue somewhere. So that is an AD, and it is specific to the level of injury, above T6 only.
That's great. Sorry to confirm that's answered a question. I think that's all the questions that have come in. I'm sure as people kind of go over the webinar again, there'll be more that pop up. And I noticed you pop your email there, Shiva, in the first slides. If it's okay for us to share those with everyone who's joined, I'm sure you can reach out to Shiva directly or ourselves, and we can get the answers. Yes. So that's been great. I really appreciate you coming on, Shiva, and sharing that with us all. Just to wrap up now, so just really to point you to our website, just that we've got a online occupational therapy, not just limited occupational therapy, of course, but kit really on there. So in terms of specifying seating or looking at movement and handling, there's any justifications or templates or previous webinars, so on. You know, it's your resources to jump on there and download free of charge. So just to encourage you to do that. So thank you very much again for joining us. Appreciate taking your time this afternoon. Sure there'll be more webinars in the future, but just to thank Shiva again very much for her time and enlightening us on spinal injury management. Thank you very much.
Thank you.